about fetal Dopplers, and I'll be speaking in the context of IUGR. So before I move forward, I'd just like to touch upon the basics of ultrasound. The basics of ultrasound imaging is that in ultrasound scanners, a series of pulses are emitted, which touch the tissue interfaces, and some part of the sound beam is reflected back. And this reflected beam is called echo, and this echo is processed and displayed as an image. So in Doppler, the machine has to image a moving object with a particular velocity. Now, we know the incident wave is transmitted at a particular frequency. Now, the reflected wave from the moving object, as in our case the RBC, if it's traveling towards a probe, the frequency is more. And if it is moving away from the probe, the frequency is less. So this is a change in frequency, also known as the Doppler shift. And this is translated by the machine to velocity. And it depends on the velocity, initial frequency, and the angle of incidence. And it is represented in the formula here, the Doppler shift. As you can see here, the velocity, the Doppler shift is directly proportional to the angle of incidence between the ultrasound beam and the direction of blood flow. That is, if the angle is 0, the cos 0 is 1, which depicts true velocity, and that is calculated by the machine. Coming to Doppler indices, the common Doppler indices are based on systolic and diastolic flow, which is depicted in the form of a graph and in relation to the cardiac cycle. And the most common indices are ST ratio, resistive index, and pulsatility index. And PI is the most commonly used index in the current practice because among them, PI has a linear correlation with vascular impedance in the placenta, which increases with increasing vascular impedance. And there are nomograms which shows the PI for the period of gestation, which is represented in a graph. So, what is the use of Doppler in our context? When an AC is less than 10 centile, the Doppler helps us to distinguish it between a constitutionally small fetus and a fetal growth restriction, which has uteroplacental insufficiency, hypoxemia, and acidosis. So I'll be just speaking very briefly about uterine artery, umbilical artery, MCX, CPR, ductus, umbilical vein, when to do it, the methodology, and how to interpret it, because these are all the components of the staging which you'll be hearing in subsequent lecture. So umbilical artery Doppler, it is a measurement of the placental impedance to blood flow, and there's a progressive rise in the end diastolic velocity, and there's a decrease in the pulsatility index. So, and the flow impedance is increased only when a significant part of the vascular bed is obliterated. So, when is the umbilical artery assessment indicated? In reduced fetal growth velocity and fetal growth restriction, in monochorionic twins and high drops. So, methodology and how do you assess it? So, you visualize the cord, select a free loop that is not too close to the fetal cord insertion or the placental insertion. Zoom up, magnify the area of cord, switch on the color Doppler, optimize the flow. Then you place the sample gate on the umbilical artery and start the pulse Doppler function. And this is a normal umbilical artery flow. As you can see here, there's a physiological increase in peak systolic flow velocities, especially in the diastolic velocities with advancing gestational age. And the absence of diastolic flow at 10 weeks is a normal finding. And also the resistance in the placenta falls progressively with the advancing gestational age. So a normal umbilical artery will have low resistance and a good forward flow in diastole. So how do you interpret an abnormal waveform is when it has a high PI and there's a decreased forward flow in diastole. There's an example for abnormal waveform that is an absent end diastolic flow. As you can see, the diastolic flow is 0. It usually happens when 60 to 70% of villus vessels are underperfused. And this is an example for the reverse end diastolic flow. And there's an increased rate of perinatal mortality in such cases. Coming to uterine artery Doppler, it's a dynamic evaluation of the uteroplacental function and reflects the degree of resistance to flow. And usually in non-pregnant and early pregnancy, the resistance is high and the resistance decreases as the pregnancy progresses. So in case of impaired placentation, there is abnormal blood flow and resistance, and a persistent high resistance increases the chance of preeclampsia and IUGR. So when should it be performed? We heard in the morning Performed in high-risk pregnancies, FGR in previous pregnancy, mothers with APLA, inherited thrombophilias, and other factors related to poor placentation. Methodology, how do you assess it? First of all, obtain a SAD section of the uterus, identify the cervix and internal loss, tilt the transducer side to side, use a zoom function, color flow is put, and identify each uterine artery at the level of internal loss, and sample volume is placed at 1 centimeter downstream from the crossover point of uterine artery and internal iliac. 2 mm sample gate is done with an angle inclination of less than 50. 3 consecutive waveforms are taken and mean PI is calculated. Why should it be done in the first trimester? The aim is early identification of women at risk of early onset preeclampsia, and we can also predict early onset IUGR. And the most important thing is the availability of intervention is available if screen positive, which we heard in the morning and we'll be hearing in subsequent lectures. Now this review on second trimester uterine artery Doppler suggests that if found abnormal, can identify 40% of those who can develop preeclampsia and 20% of those who can develop fetal growth restriction. So how do you interpret it? A normal one would have a low PI and it has a less than 1% chance of developing preeclampsia and or IUGR. How do you interpret an abnormal? It is when the PI is greater than 90th centile, which is significant. Notch, as we heard, it is not used anymore and PI is given importance. So a combined screening at the first trimester and second trimester, you can see a steeper decrease in uterine artery PI and it has a normal outcome, and a persistent raised PI, there's an increased risk of early preeclampsia with a detection rate of 90% and false positive rate of 5%. Coming to MCA and CPR. CPR is the PI of MCA divided by the PI of umbilical artery. And we know MCA dilatation is a marker for hypoxia. And CPR, however, becomes abnormal even before MCA and is more sensitive than MCA. However, MCA is more specific for fetal hypoxia. When is it performed? For detection of FGR and fetal anemia. Fetal anemia, we consider the peak systolic velocity. And it is an important tool in differentiating between late onset IUGR and SGA fetus. As you can see, is one of the components to differentiate the same. The methodology, how do you assess it? It is obtained just below the BPD plane at the circle of Willis. Use a zoom function. Sampling gate at the middle 1/3 of MCA. 1 to 2 mm sample volume is taken. Use gentle pressure. Use angle correction. Incident at 0 degree. And adjust the Doppler scale waveform, and that's a normal MCA Doppler. In evaluation of fetal growth restriction, an abnormal one would be reduced PI and increased forward flow. As you see in this figure B, you can see the increased forward flow in diastole, and both are suggestive of cerebral redistribution and brain sparing. Coming to Ductus Venosus. We know that it is a vascular shunt which directs the oxygenated blood, that is 30% from the umbilical vein to fetal heart and brain. So degree of shunting actually depends on the vessel diameter, pressure gradient and blood viscosity. It is performed in fetal growth restriction, an assessment of compromise of fetal cardiac output, and also as a screening for aneuploidies in the first trimester. How do you assess? We have 2 methods in the first trimester. You obtain a mid-SADS view of the trunk with adequate magnification of the trunk. Put on the color Doppler. The ductus is identified as the area of ALIC. You put on a sample gate of 0.5 to 1 mm. The angle of inclination should be less than 30. Use a low filter, 50 to 70, and a high sweep speed of 2 to 3 centimeter per second. The second method is the axial section, axial scan through the fetal abdomen. Use a zoom function, use a color Doppler to find the duct, and it is seen coursing between the umbilical vein and the IVC. And place the sample gate in the middle of the vessel, adjust the scale, and the normal DV Doppler trace, as you can see here, is a triphasic flow pattern. So the ductus venous waveform, just a small mention of the SD and A wave. S is the highest velocity peak. This is a ventricular systole. D is again a forward flow. The early diastolic passive filling, and A is the lowest velocity, suggestive of atrial contraction. So how do you interpret it? Is a quantitative assessment is by assessing the PI, and a qualitative assessment is by assessing the status of the A wave, which is either forward flow, whether it's absent or if it is reversed. Please be aware of the contamination from umbilical veins and hepatic veins. So it's an isolated finding in about 1% cases, and in the presence of an increased NT, it is all associated with other chromosomal abnormalities and cardiac abnormalities also. And in MCD twins, there is an increased risk of TTTS. And it also forms part of the staging of IUGR in Barcelona protocol. In stage 3, DB is greater than 95th centile, and stage 4, there's a reversal of DB. Just a small mention of umbilical vein Doppler. It's a pulsatile flow in early pregnancy. However, it becomes a non-pulsatile in the second trimester. And the presence of this pulsatility in the second trimester indicates a severe pathological state and is an obvious sign for severely compromised fetus. As you can see here, there's a continuous forward flow without pulsations is established in the first figure. And the second one, you can see the pulsations. And it's characterized by a triphasic pattern, and the fetal mortality is imminent. The presence of pulsatile umbilical venous flow in IUGR suggests a 5-fold increase in perinatal mortality rate. Just one slide on aortic isthmus. As you can see here, there is a brief retrograde flow at the end of systole. In the first one, that is a normal. Whereas in the second, there is a reverse in the late systole, and the net flow is retrograded diastole. So a retrograde diastolic aortic isthmus waveform has been shown to be associated with poor neurodevelopmental outcome. There are papers for and against for the same. So to conclude, fetal Doppler, we can assess the fetal and pregnancy pathophysiology. It can be done in all trimesters for different indications. It can be used as a screening as well as a diagnostic tool, and it can indicate abnormal placentation, fetal hypoxia, anemia, and impending heart failure. However, operators should use it skillfully with a knowledge of its potentials, limitations, and dangers.